Hi everyone, I want to talk about DKA, diabetic ketoacidosis. Diabetic ketoacidosis. Okay, let's go. Diabetic ketoacidosis will present either as the first sign of type 1 diabetes mellitus, or the individual has been diagnosed with type 1 diabetes mellitus before, but not had any to dietary control and insulin regimen. So the individual is now down with high level of glucose, acidosis, and every other thing. The clinical features will be polyuria, polydypsia, polyphagia, weakness, weight loss, fungal infections, particularly those that have been diagnosed for a long time and they are now immunocompromised, abdominal pain, dehydration, anorexia, nausea, vomiting, cosmal respiration, tachycardia, tachypnea, drowsiness, decreased level of consciousness, acetone breath, coma, and death if not treated on time. The precipitating factors could be infection. The individual is having type 1 diabetes mellitus, now having infection that could tilt the individual to diabetic ketoacidosis. Infarction or ischemia, when there is impaired circulatory flow, impaired blood flow, and ischemia or infarction of the intestinal organs. Insulin mixed, that is, the individual is not adhering to checking the glucose and taking the injection of insulin as been prescribed. Intoxication with alcohol. Okay, illnesses associated with condition that could lead to nausea, vomiting, and dehydration. And of course, medications like steroids or second generation antipsychotics that could all shoot up the level of glucose. As a matter of fact, for medical students, there's what they call 5 I's of precipitating factors leading to diabetic ketoacidosis. That would be infection, infarction, ischemia, insulin mix, and intoxication. So I've added another I here, illnesses with 1M medications like corticosteroids and second generation antipsychotics and so on. The investigations to be done, for obvious reasons, you all know we're going to check glucose, right? Okay, it is expected to be very high and greater than 14 millimoles per liter is possible. We are going to check the level of acidosis. We expect venous blood gas or arterial blood gas to reveal pH less than 7.3. And when we check the bicarbonate, it's going to show a low level, lower than 15 milliequivalent per liter. Normal is 22 to 26 milliequivalent per liter. When we check the ketones in the urine, it's going to be high. So ketonuria. In the centers where beta-hydroxybutyrate could be acid, that is a plus, because increased level of beta-hydroxybutyrate greater than 3 millimoles per liter is likely going to happen here. And you check the annual gap, normal range is 8 to 14 millimoles per liter. Check your phosphate, that's likely going to be lower. Check the sodium, that's likely to be down. Check magnesium, that's likely going to be low. And when magnesium is very low, then you need to find out with EKG what is happening to arrhythmia there. Because with low level of magnesium, you are likely going to have long QT syndrome, And with the long QT syndrome, you can have torsade point. With torsade point, you are going to treat the patient to ventricular tachycardia, and from there to ventricular fibrillation, asystole, and death. And of course, our big brother here, potassium. We're going to assay potassium, and it's going to rise. Still on investigation, we're going to check blood urea nitrogen and creatinine that will likely be high. Amylase and lipase, because sometimes the pancreas could become, affected with pancreatitis, so the level of amylase and lipase will give clue that there's a problem with the pancreas already. Then venous blood gas with level of PCO2 is very important. Hemoglobin A1C, yes, it's expected to be high, but who knows if the problem is within a short time and the individual has been controlling the glucose level very well before, but just missing within few days, then hemoglobin A1C might not be that significant at this level, because hemoglobin A1C is a function of about 3 months level of treatment effectiveness. If comatose, then we have to do toxicological screening, because you might think this is only DKA and it might be strict drugs that has treated this individual to this stage. When the individual is comatose, you want to be safe, either for the purpose of saving the life of the patient or for medical legal reasons, do the CT head. Maybe this person has had trauma. The fact that is having type 1 diabetes mellitus doesn't mean you cannot be involved in something else, and something else is even responsible for what we're dealing with right now. Okay, if there is raised amylase and lipase, then we need to check calcium level, because with pancreatitis, we know what is likely going to happen. It's likely going to drop. How do we classify DKA? Now, the check mark there, my computer generated that, well, I like it, but I don't like DKA. It is mild when the pH is between 7.2 to 7.3. It is moderate when the pH is between 7.1 and less than 7.2. It is severe, and I'll show me a sign of drop in temperature here. It is severe when the pH is less than 7.1. Okay, here we go. Treatment. Yeah, the main reason why this is being presented is because of this. Check the airway for foreign body, for any secretion, suction as is appropriate, and mechanical removal as is may be applicable. Check the breathing, the central cyanosis for peripheral cyanosis, the chest moving with respiration, any obvious deformity along the chest, count the respiratory rate, know the value of the O2 sat, and if you have arterial blood gas or venous blood gas, check the parameters. For C, that is circulation, get the vital signs. What is the pulse saying? What is the blood pressure saying? Fluid in and out. And of course, you auscultate for any crackles or heart sounds abnormalities. Get 2 IV lines set, please, because you're going to pass IV fluid and be doing a lot of laboratory investigations. Pass fluid catheter, because this is not the individual that will be getting up and be going to washroom. So you need fluid in and out. The IV fluid should be at the level of 20 ml per kg of normal saline. And you check the renal function, check vital signs, check fluid in and out, calculate the deficit, rule out septicemic shock, and replace deficit with half saline. Insulin is the essential medication here. And we're going to start insulin infusion at a rate of 0.1 units per kilogram per hour. That will continue while we continue to monitor the glucose level every 1 hour. And when we reach a level between 15 to 14 millimoles per liter of glucose, then we're going to change the IV fluid to D10 or D5 in half saline. When we're going to continue that is the IV fluid with glucose and insulin until the patient is awake and can take per oral. When glucose drops, we expect potassium to drop, and we expect the sodium level to normalize with the insulin administration. As far as potassium is concerned, decreased pH will lead to acidosis and increased potassium. Potassium drops when acidosis is corrected, and potassium greater than 5.5 milliequivalent per liter will warrant EKG. So get EKG done, continue the insulin infusion, and repeat the laboratory to know the value of potassium in the next 1 hour. That is if it is greater than 5.5 milliequivalent per liter. But if the potassium is between 5.5 and going down to 3.5 milliequivalent per liter, we have to add potassium chloride 20 milliequivalent per liter and continue the insulin infusion. But if the potassium is below 3.5 milliequivalent per liter, we have to stop insulin infusion, please. We'll stop the insulin infusion and add 40 milliequivalent per liter of potassium chloride. Part of the treatment is to monitor so many parameters. I will tell a small story here. I remember during the days when I was in internal medicine during internship, there was this young man who came down with DKA, and when I got to the lab, many other members of staff were there, but specifically the individual in charge of Electrolyze was not there. He had gone home, I don't know whether temporarily or whatever. Then I informed the head in charge, and they said they were going to send ambulance, and my senior reg said, if you don't mind, you can go with the ambulance so that the man will know the importance of waking him up at the middle of the night. It was about 2:30 a.m. to 3 a.m. the middle of the night. So I went with the ambulance man to his house to plead with him. Please, we just need your services right now. Because it's like a blind procedure if you are treating DKA without the facilities or the availability of monitoring so many parameters. Okay, with that, let's go. So we monitor vital signs every 1 hour. That is, I need to know the blood pressure, the respiratory rate, the heart rate, the temperature, is there any pain, and what is O2 SAR telling me every 1 hour. And I trust the wonderful nurses, they'll do that. Fluid in and out every 1 hour. Neurological status every 1 hour, and of course blood glucose hourly. We need to monitor some other parameters every 2 hours. Electrolytes like potassium, sodium, and chloride, arterial blood gas or venous blood gas, and beta hydroxybutyrate level every 2 hours. At every 4 hours, we need to check the level of calcium, phosphorus, and magnesium. And while replacing potassium, we should remember to replace phosphorus at the same time, so that we'll replace potassium and phosphorus together. The possible complications here are venous thromboembolism, cerebral injury, pancreatitis, and death in some. We continue our subcutaneous insulin when the patient is awake and eating until we are comfortable that the individual could eat and administer the insulin as may be expected. We'll continue to check glucose level, take further history, complete physical examination, review the insulin dosage, and make adjustments as may be appropriate. We are going to address any psychosocial issues and involve social workers. We will discharge this man or woman to a family physician, and then you can wash your hands clean that you've helped to save this life. Thank you for listening to my presentation. Kindly subscribe so that you can get these presentations immediately they are published. Thank you.